All right, everyone. It's me, Brahm. Welcome back to another episode of the podcast. It's been about 6 months since we've done one of these, so time to kind of reboot it. And we have a really awesome guest here to help us explore some very interesting questions. There's a lot of uncertainty about the economic and financial future of psychedelic therapies. How much are these things going to cost? Will insurance cover them? And more fundamentally, how does one even begin to quantify the economic value of a psychedelic experience? Today's guest is here to help explore all these questions and more. Today's guest is Dr. Elliot Marseille. Dr. Marseille is a leading expert on the economics of the emerging psychedelic-assisted therapies. He is the founding director of the UC Berkeley's Global Initiative for Psychedelic Science Economics, abbreviated as GIPSE, a network of health economists and health services researchers dedicated to realizing the potential of psychedelic therapies for high-priority mental health conditions. Through the application of policy-relevant economic analyses, GIPSE seeks to enhance the efficiency of service delivery and increase access to these promising therapies. Elliot, thanks so much for coming on the podcast today. Really appreciate you joining us.
My pleasure. Glad to be here.
And of course, also we have the other half of Empath Ventures, Sam Tabone. Hey, Sam.
Hey, Brahm. Thanks for having me.
Yeah. So, Elliot, just before we dive into the details of healthcare economics and how it applies to psychedelic therapy, maybe you could give us a bit of a backstory. I've kind of looked around for people doing the type of work that you're doing, and it seems to be that you're one of the only people, or at least on the academic side, that's really researching this stuff in a rigorous way. So, what led you here? How'd you get into psychedelics?
Yeah. So I was born in San Francisco and raised in Berkeley, and came of age really in the height of the summer of love and the psychedelic counterculture of the 60s. So just to be a little graphic about what that means, when I was in high school and college, I had hair down to here and I wore beads, and I considered myself a hippie, but I wasn't really a hippie because I was on a track to go to college, which I did. So, and yet the aesthetic and the ideas of that moment were very much part of the air I breathed and part of my life. And then the other thing is that I like to say that psychedelic science, or the use of psychedelics, is my family business. And what I mean by that is my father was an orthodox Freudian analyst who had a practice in Berkeley. And in the early 60s, he got a supply of LSD from Sandoz, which was making it available to qualified researchers and psychotherapists and psychoanalysts and others, because Sandoz they knew they had something interesting and important, but they didn't know quite what to do with it, and they wanted information about how it could be used. Anyway, so my father provided it to his patients and also used it himself. And I remember as a child, so I'm like 8 or 9, his describing his own LSD experiences. And I was really intrigued. I thought it sounded magical and wonderful, actually. So that's one thread. And the other thread is my mother she died last year at the age of 99. She was a psychiatric social worker and did family therapy and couples counseling and all kinds of counseling. And she started using psychedelics with her patients after having met Leo Zeff. And for those of you who aren't familiar, Leo Zeff, also known as the Secret Chief, is one of the pioneers of what is now kind of the standard way of approaching psychedelics in a structured setting. So you go inward, listen to carefully curated music on headphones, eye shades. It's not really conversational, it might be, but mainly the sitter is holding space. It's not really guiding or therapy. And so Leo I think it's accurate to say he was one of the main pioneers of that effort. And and so my mother knew Leo, and they had a referral relationship. So both parents sort of independently were involved in psychedelics. And then it's probably reasonable to suppose that I did some of my own experimentation when I was young. Um, so it's been a part of my life for a long time, but became a part of my professional life when I had a serendipitous meeting with Rick Doblin at Burning Man. So it was a retraining of people who sit at Zendo and support people who are going through challenging experiences, usually with psychedelics. And anyway, I had an encounter with Rick, and he said, what do you do for work? I said, I'm a health economist. He said, we need you. And I said, okay. And so I really shifted the emphasis of my professional work. And now I am full-time looking at the economics of psychedelic-assisted therapies. Yeah.
That's an interesting origin story. At the risk of getting off topic, I kind of have to ask, like, when you look at, the fact that your father was this psychoanalyst that was using LSD back in the day, and now you have a front row seat to this new generation of therapists and pharmaceutical companies trying to do a similar thing. Are there any obvious similarities and differences? Are we just rediscovering the things that your father knew all along, or is there anything new that we've come up with?
No, emphatically not. What's happening now is different. So just speaking for my father, and I don't know that he represents all of what was going on at that time. I'm sure he didn't. He was an orthodox Freudian analyst. And when I talked to him later when I became, last time I talked to him about this, I think I was age 16 or so, he said that he was uninterested in any of the other effects of psychedelics and ignored them. The only thing he was concerned about was he was convinced that it was a powerful tool for uncovering repressed memories that were causing neuroses in the life of his patient. So standard Freudian kind of conceptual framework, and all of the other experiences were just a distraction, which I find amazing that one could kind of discount everything else. But anyway, he was focused on a Freudian model, and as you know, that model is not exactly at the forefront of progress, I would say, in where we are in terms of therapy and analysis.
Thank you for that. That's very interesting. So getting back to kind of this topic of the healthcare economics of psychedelics, in your work at the institute that you're working with at UC Berkeley that you founded, what are some of the big overarching questions in maybe healthcare economics in general? Like, for most people that are listening to this don't really know much about this field. What are the big questions that it answers? What's some of the terminology that's used? People throw around these things like QALYs and ICERs. Like, what does all this mean? And like, what are the goals of this field? How does this field help drug companies set prices and insurance companies figure out if it's worth paying those prices, et cetera? Can you just kind of give us like a high level guided tour?
Sure. Yeah. So we do a wide range of economic analyses, but much of it centers on cost effectiveness analysis. And it's probably useful to just give you a slightly, well, no, I'm not going to say a technical definition, but kind of, because cost effectiveness analysis, sort of like people say, oh, this is cost effective, that's cost effective. And it kind of means it's a good thing to do, or, maybe. People are a little vague. It's value for money. And more precisely, if something is cost effective, what we mean by that is you're getting more benefit per dollar spent on that intervention than on some competing like standard of care or some other comparator. So it's always comparative. And the question is the intervention that you're evaluating better value for the money? Do you get more a bigger quantum of health benefit for the money spent than the comparator, whatever it is, usually a standard of care. So for psychedelic therapies, let's just pick one, like psilocybin for depression. The question that we want to answer is psilocybin-assisted therapy, does it reduce measurable severity of depression more effectively per unit of money spent than conventional treatments like SSRIs? And I think what some people may not be so familiar with is, of course, you can quantify money, so the cost of the therapy, and also the reduction, hopefully, the reduction in healthcare utilization and healthcare costs that people experience as their symptoms get better. Okay, so that's kind of the quantitative side. Cost of therapy, change in healthcare costs over time. But we also quantify health benefits. And so you mentioned QALYs, which is a term that's thrown around a lot, quality adjusted life year. And it is a way of combining reductions in mortality with improvements in health, so reductions in morbidity and reductions in mortality, and putting them together in a synthetic outcome measure, which we call a quality adjusted life year. So we're able to quantify and put on an apples to apples basis the benefit that might come from, let's say, psilocybin for depression versus conventional therapy for depression. So which one generates the most QALYs? And I'm going to just throw out one more technical term because we may return to it later in the conversation. We economists use the term utility to measure health status. So zero, it goes from 0 to 1. 0 is you're dead. 1 is you have no symptoms. In other words, you don't have a diagnosable issue. And so everything is between 0 and 1.0. And that's the way we measure health. That's a key ingredient in the quality measure is changes in utility. But the reason I want to, maybe I'll mention this now rather than hoping we get to it later, is I believe that the benefits of psychedelic therapies are somewhat underestimated because, as I said, we top out at 1.0, which just means, like I said, you don't have a diagnosable condition. But, you could be like waking up in the morning and be excited about your day and greet your partner with enthusiasm and jump into your work. And I could drag myself out of bed and be telling myself, oh my God, I have to face another day. And we would both get 1.0 because in this example I'm giving, nobody's depressed. Nobody's clinically depressed. But what we know about the effects of exposure to psychedelics, both in clinical and non-clinical settings, is that people seem to have greater access to positive emotional and cognitive states, and we're not capturing that. And this is something we would like to tackle, is adjusting utility measures to include these positive health states.
That totally makes sense. And I mean, you could say that's kind of a critique of modern medicine as a whole, is that it focuses on, fixing problems, not necessarily improving you above baseline, right? Like as long as you're in the normal range, you're good to go. And so we care about normal range and below normal range. Anything like above that is kind of, I guess it's a nice to have, but we're not going to bother tracking it or measuring it. And it's funny that you brought this up as a thing you wanted to emphasize, because I was reading your papers in prep for this call, and there was one thing that stood out to me and I snipped it. You said, and this is just reiterating what you just said on the call, but the exact quote was, health state utility ranges from 0, signifying death, to a maximum of 1, which signifies the absence of disease. Utility is thus not equipped to reflect sustained, enhanced access to such positive experiences as awe, compassion, self-efficacy, and affinity with nature. And I thought that was just a beautiful way of putting it. So I'm glad you're paying attention to this stuff. It's nice that not only are you working in the field, but kind of working to expand the definitions of things and capturing some of the stuff that's currently not captured. So I know that a lot of your work has focused on the cost effectiveness of MDMA assisted therapy. I know you've done a couple of different analyses based on the MAPS phase 2 and phase 3 data. What are sort of the headlines or the highlights of those analyses? Is MDMA cost effective? I think that's a question that a lot of people are asking now, seeing as MDMA is likely less than 12 months away from FDA approval. Also, for additional just cultural context, I guess, Spravato, which is the one psychedelic-like FDA-approved psychiatric drug on the market, Johnson & Johnson finally started reporting revenues. They're generating about $500 million in sales per year from Spravato, which I think surprised a lot of people. So people seem to think it's cost-effective if they're willing to spend that much money on it. So where does MDMA stand, at least according to your analyses?
Yeah.
And how did those analyses work?
Yeah. So MDMA for severe or extreme chronic treatment-resistant PTSD is not only cost-effective, but likely to be cost-saving to the healthcare payer. So the distinction I'm making there is, and this is another point that people sometimes get a little confused about. Something can be cost-effective without saving money. Most of healthcare is. It doesn't save money. You have to pay for the treatment, but it's good value for the money. You get lots of health benefit. That's what it means to be cost-effective. This is beyond cost-effective, where it both generates significant health benefits in terms of relieving PTSD, but also over time, so it saves the healthcare payer money because people don't need to access ongoing treatment. So MDMA for PTSD, for the class of PTSD patients that I mentioned, what we find is that, like I say, it's not only cost effective, but cost saving. And so we would expect that healthcare payers would look at this and say, this provides excellent care for our patients. And oh, by the way, it looks good for our bottom line. So I'm pretty confident that of these findings. It's kind of like like all modeling, there's substantial uncertainty. But in the work that we've done, you can kind of throw any reasonable, more conservative, more negative estimate of a key variable, and it won't change the substantive result, which is that this looks to be cost effective, if not actually substantially cost saving.
Yeah, I think in your paper you had a pretty comprehensive sensitivity analysis, but just can we state what the estimated cost is, at which point it is cost saving? Like what is the estimated cost that you think it's going to end up at?
For the cost of the therapy?
Yeah, what is the cost of the whole all-in cost of the therapy, including the MDMA itself, the people supervising, et cetera? Because that's what we're talking about, right? The comprehensive cost has to be cost saving or cost effective. And
correct. Yeah.
Right.
So
where do you think that's going to land for the MAPS MDMA therapy?
Yeah. So when we did our analysis, we used a lower cost of the MDMA itself than it looks like it's going to be. Now, we don't know what the price of MDMA is going to be. MAPS is, working on this, obviously a critical question. They're working this through. They may not make a decision until after FDA approval, and they understand, everything related to the REMS and the kinds of patients that it will be available to treat, and so on. There are a lot of factors there. So I do really, if it sounds like I'm hedging, it's because I am. I don't know what the cost is, but I've got a pretty good sense that it is something like $25 a milligram. So it works out to about $3,100 per dose. So I was looking at, when I published, we had much, much lower estimates based on the thinking at that time. So the cost of the therapy is going to be considerably higher than the numbers that were in my paper. And in fact, it looks like the cost of the medication itself could be about 50% of the total cost of the therapy. And in a group therapy context, it could be like 2/3 of the cost of the therapy itself. So here's a kind of weird thing, or slightly counterintuitive thing. Even though it looks like the cost of the therapy is much higher than what we estimated, it has very little effect on overall cost savings and cost effectiveness, because although it's a big upfront cost, and now bigger than our previous estimate, if the benefits last for even 5, 6, or 7 years, and there's reason to think that benefits will be at least that durable, the savings in healthcare costs overwhelm that, and you're still in the territory of being cost saving.
That makes sense. So just to kind of like put some numbers on it, you said approximately 3,100 a dose. I think the MAPS protocol is 3 doses. So that's about 10 grand. And then another 10 for therapy, approximately. Of course, this is rough. And you mentioned earlier when we were talking about this, that it's all about comparison to the standard of care, right? So is it fair to assume that, getting back to the question of how much is the actual therapy, not the drug, but the therapy going to impact the total cost, the comparison is to people just going to therapy without the drug, right? That's what people that have PTSD at the moment do, is that they go to therapy. So are you increasing the cost of therapy, or are we just rerouting dollars that would already be spent on traditional therapy to psychedelic therapy instead?
Right. So we're comparing MDMA assisted therapy with ordinary standard of care, whatever that is. So remember, these are people who have chronic treatment-resistant PTSD. So this is a group of people for whom nothing has worked. So they're getting SSRIs, which may be helping a little bit, and maybe the dose is being adjusted from time to time. Probably most of them are done with talk therapy at this point, but they're getting whatever they're getting. Let me put it that way. So that's the comparison for this class of patients. If we're looking go ahead.
No, please go ahead.
Yeah. If we're looking at expanding access to less severely and less treatment-resistant patients, then the comparator is very different. Because as a first-line therapy, talk therapy, SSRIs, EMDR in particular, are actually quite effective for PTSD, for sort of incipient and milder cases. So typically 50% could have substantial improvement or remission. And so in that situation, it's not clear at all that MDMA-assisted therapy would be cost-effective. And I could elaborate more on why that's likely to be true, but I think maybe for now, simply to say that the more severe and the more treatment-resistant the PTSD is, the bigger the contribution that MDMA-assisted therapy can make, and the more cost-effective it is.
That totally makes sense, especially under a regime that doesn't include those like extra benefits in the utility function, like we were talking about before. If it's just about improvement, then yeah. I've been hogging up the questions. Sam, did you have anything that you wanted to ask?
Yeah, I have a few, but I guess, I was pretty intrigued when you were talking about how health state utility and that metric doesn't really account for some of the more subjective elements of psychedelic assisted psychotherapy. And, in your most recent paper, you also highlight these 6 areas of economics research that you say would be useful in shaping future policies and programs. And so do you think that these different types of analyses will have to be tailored to psychedelic assisted psychotherapy in some way specifically? And are you working towards that right now? I know you mentioned methods development as one of these 6 areas. What are some examples of what that looks like?
Yeah, great. So for the most part, tried and true methods of economic analysis or health program economic analysis are applicable here. And my background is in global health and HIV/AIDS treatment and prevention, evaluating the economic dimensions of HIV interventions. And I found that I could, basically import most of that conceptual framework and sort of analytic apparatus for psychedelic therapies. One important area where we do want to develop methods is the one that we've been discussing, is taking more fully into account the effects of exposure to psychedelics, and really getting back to kind of a WHO definition of health, which is, I'm gonna mangle this, but sort of the idea is not merely the absence of disease, but positive mental, physical, emotional, social health. Something like the full realization of individual potential. So this utility question is really kind of front and center for us in terms of methods development. Then the other thing, this isn't like breaking new ground in methods development, but an area that we want to move into. We've been kind of narrow in the way we've assessed cost effectiveness so far, in that we've looked at it from the payer's perspective. And we're doing that for a very important reason. Like, payers really need to be comfortable with, what is this going to cost? What can they expect for potential downstream savings? What are the benefits going to be to their members? So we really, that is so important now, to address the concerns that payers have, so that they adopt these therapies. So that's been our focus, but there are other aspects of the effects of these therapies that are not captured by the payer. For example, the healthcare payer. So, for example, like the big one that people talk about a lot is productivity effects. So, as people feel better, they can return to work. They have fewer absentee days. There's also this weird phrase. I just find the word kind of interesting. Presenteeism, right? So absenteeism is you don't show up for work because you're feeling depressed. Okay, so that's lost productivity. Presenteeism is you're present, but you're not being very productive. So there are estimates of the presenteeism effects of depression, for example. And so we're moving forward now on analyses that take this broader social perspective into account. So it's not just the healthcare payer, but now we're looking at productivity effects. And there are other effects as well, like involvement with the criminal justice system. People with PTSD sometimes get violence associated with domestic violence from time to time, other involvement with the criminal justice system. So we want to estimate those other social benefits of psychedelic therapies. So certainly for PTSD, and then psilocybin for alcohol use disorder also has those other elements. Ibogaine, perhaps, for opioid use disorder. So we want to expand the accounting of benefits. We think this is really important for advocacy. So, I'm imagining somebody giving testimony to Congress at some point, advocating for funding for these therapies, and to be able to say, not just from the healthcare payers' point of view, but for society more broadly, here's what's at stake. Here's the cost of not making these therapies available. Yeah.
I was just about to say, so basically, the work that you're doing right now is obviously going to be important in informing these future policies, but even post, MDMA assisted therapy rollout, I think what we see in practice is definitely going to be different than some of the assumptions and projections that are made now, of course. But would you agree that there are maybe some elements of the assumptions that you make that may turn out to be starkly different in practice? And this is probably going off on another tangent. So, Bram, I don't know if you had a comment to make on the other stuff, but one of the things that I think about a lot of the time is this assumption that there are service centers available, and they'll be ready to go for MDMA assisted psychotherapy right away at capacity. Do you foreshadow a scenario where it's not as smooth, and perhaps maybe the economic projections of the profitability of MDMA assisted therapy for companies are completely off? And will this affect the future policy and programming that you mentioned in your paper?
Yeah. And maybe just on the same question, but more broadly, like, what can go wrong? What do we need to make sure we get right in order for all this stuff to pan out?
Yeah. What could go wrong? Yeah. So it's pretty well established. It's sort of the efficacy effectiveness difference. So efficacy is what you see in highly resourced, carefully controlled clinical trial settings, and effectiveness is what happens in the real world. So I could imagine changes in the benefit that people get from these therapies in a real world context, and it may be on the negative side. So, for example, a lot of people are excluded from clinical trials due to various comorbidities. They're carefully screened out. And in the real world, that's less likely to be done as rigorously. So we don't know, but it could be that these therapies are less effective with people who suffer from the comorbidities that have been screened out in the trials. So that could result in less benefit. On the other hand, on the cost side, I'm expecting innovation in the staffing and structure of these therapies. So we've done some work on group therapy, which is something that's talked about a lot as a way of reducing costs. And we are in the advanced stage of a manuscript for publication that documents what the savings would be related to group therapy. There's also interest in having peer therapists who would be paid less. So there are other ways of reducing costs. So that would help on the cost effectiveness side. However, much of that will be sort of swamped by the price of the medications. That's really kind of the elephant in the room, what the price of psilocybin and MDMA ends up being.
But those will end up becoming generic somewhat quickly, at least in the case of MDMA, as far as I know. Yeah, like they maybe have 5 years of exclusivity, and so by 2029, maybe there will be generic MDMA that therapists can use instead.
That's right. Yeah.
Yeah.
So
that really changes the calculus.
It really does. No, you're making an important point there, Bram. This is a temporary situation. And the other thing is that over time there is on the part of pharma companies who are looking to patent new molecules that have different properties and so on. It may turn out that while they have a patent, there's enough substitution between these different molecules. So somebody's got a novel MDMA molecule, and somebody else has got another novel MDMA molecule or a new psilocybin type molecule. And they're all roughly equally effective in treating a given condition. It would seem to me that some kind of price competition would start to set in. So that may be helpful.
I think that's a great point. We invest in psychedelic startups, and I've always been very critical of these simple tweaks that people are making to these molecules, because I just can't imagine that, like, therapeutically, there's that much of a difference in the long run. So people will just use what's there. I wanted to go back to something you were talking about earlier about quantifying I think the word you used was societal costs rather than just the costs to the payer. How does this discussion, I know the first word in the name of your organization is global. So when you go outside the US, how do these conversations change? How does this look different from both a payer perspective and societal perspective?
Yeah. Well, many other countries have a sane healthcare system, which we don't in the United States, or at least relatively sane, where there's a single payer, so that the government is paying for most of the cost of healthcare, and they therefore the societal benefits, which are not captured by healthcare payers in the United States, are in fact it's a reasonable proxy for societal benefits. So that's one advantage that other countries have in terms of capturing the full benefit and being able to make decisions based on the full benefit rather than just part of the benefit of these therapies. I mean, something like productivity is it depends, but it can be half or 75% of the value of the savings in the healthcare. I mean, it's not true. It's not like a little tweak. Productivity effects alone are extremely important. Yeah, as you mentioned, we are my sort of DNA in public health is global health, and I lived and worked in Nepal for 7 years and lived in India for a year, and we're really excited about helping to catalyze a conversation about what it will take to make these therapies available in low and middle income countries as appropriate. Let me just give you a couple of examples. This is all just starting in this area, but we're working with Olga Chernolas, who's a Ukrainian psychopharmacologist in Canada, who is working with colleagues in Ukraine and elsewhere to make MDMA-assisted therapy available for traumatized both military personnel, but also civilians in Ukraine. And I don't think I need to say too much about why that's morally, in every way compelling. I want to support Olga in that. So that's one thing we're doing is preparing information that she and her colleagues can use to advocate for the availability of this therapy in Ukraine. We also just formed a relationship with a prominent Indian psychiatrist, Suvarna Kantapudi in Chennai. And we're going to be presenting kind of where the clinical evidence is on psychedelic therapy to a group of maybe 200. She's the head of a chapter of the Indian Psychiatric, or maybe it's Psychological Association, I think Psychiatric Association, in the Chennai area. So we're hoping to have 200 people on a Zoom call where we'll present, here's where the clinical information is. I'll put in a little bit about economics, but more about, she believes there's a lot of interest in this, and it's time to catalyze a conversation in India about where psychedelic therapies might have a place. We're also working on a paper now to kind of evaluate, looking broadly over something like, I think, 100 low and middle income countries is what we have now, and apply some criteria about which ones it might be appropriate to begin thinking about bringing these therapies available, like looking at different criteria for feasibility and acceptability and impact, which countries would be the place to begin a conversation. And I view this as, a 10, 15, 20-year project. I like that saying about when they told me it was impossible, I knew we needed to get started right away. Yeah, something like that. So,
yeah, I like that too. Let me ask you this, just to play devil's advocate a little bit. Anytime people bring up psychedelic therapy in developing lower income countries, one of the common critiques that you'll get is a lot of these mental issues like depression and anxiety are not necessarily neurological, but caused by economic factors, right? If you're very poor, like, of course, you're going to be stressed. Do you think that if, like, this is kind of a reductive analysis, but in a country that has on average a much lower income and quality of life than in the US, there's going to be a higher percentage of folks whose depression is caused by just their economic circumstances, not anything else. And therefore, like the effectiveness of psychedelic assisted therapy might be lower in those countries because no amount of psilocybin is going to be able to help you pay your rent.
Yeah, yeah. I do think that's true, and I do not think that psychedelics are panacea, and I am big on the importance of the social and economic determinants of both physical and mental health. That's reality, and you could say that the most effective therapy is political and economic change. I have no problem with that. And I'm working on, in this particular area, and I want to maximize the contribution that psychedelics could make. Let me also play devil's advocate. Let me throw in another argument that on your
Please.
side, Ron. Why are you talking about relatively expensive psychedelic therapies in countries where people don't have access to basic talk therapy, SSRIs, antipsychotic medications, and so on, right? Yeah, we are hyper aware of that. And that's why I frame this as sort of a 20-year project. So one of the criteria for a country where it might make sense to start thinking about introducing at least research on psychedelic therapies are those that are have a relatively strong mental health infrastructure where a larger portion of people do have access. And then we could talk about bringing psychedelic therapy for making it available to people who have access to but aren't responding to conventional therapies. So so that's kind of the way I hold this.
I agree with you. I think it makes sense. It doesn't have to be either or. It can be both and.
Yeah.
Sam, did you want to jump in with something?
Yeah, I mean, hearing you both speak about this, it sounds like we've covered and touched on a lot of the different barriers that exist for scaling just generally psychedelic assisted psychotherapy within the US and beyond. To what degree would we consider cultural barriers significant when it comes to embracing psychedelic assisted psychotherapy in lower income countries? Could it be an opportunity to, help new countries embrace new therapies more sooner than traditional SSRIs, or is it going to make it, exponentially more difficult?
Oh, you mean exponentially more difficult because of sort of the stigma and novelty of psychedelic therapy? I don't have a good answer to that question. I'm just going to use a kind of dodge here and just say the obvious. Just say the obvious, which is that it's going to vary from country to country. Start again. I use this phrase, but I think it's the right one. Starting the conversation, bringing it forward for consideration, is something that can't happen too soon. And some countries will respond earlier and some later, but I think there'll be a kind of momentum or a virtuous cycle that gets instituted where one country moves forward and it kind of makes it safer to talk about it in other countries. Yeah.
Yeah, I agree. I was also wondering, maybe this question is for the both of you. Curious to know if we do end up seeing a world where MDMA assisted psychotherapy is, approved for the more general population of PTSD patients and not just the severe situations. What do we think the barriers are going to be to scaling in that sense within the US specifically to start? Is it the number of therapists? What do we see as maybe being an obstacle in the future?
Yeah, so certainly you touched on it, Samantha, the number of trained therapists. Everybody who's looked at this sees that this is going to be a bottleneck. And even if you restrict it to the subset of more severely affected PTSD patients, there's not going to be enough clinicians for a while. And there are new training programs being established, and that's good. But it's gonna take it. That will be a constraint. And that's why group therapy, while it doesn't save all that much money as in terms of the relative cost of the therapy, it does save a lot of clinician time. So, and in fact, for MDMA for PTSD, using one model that we looked at, it reduces clinician time by 50%, which is another way of saying that it doubles the effective pool of clinicians who are available to provide this treatment. Now, not everybody's going to be, yeah, yeah. I was just to say briefly, not everybody's going to be a candidate for group therapy, but there are other ways of enhancing expensive clinician time. The other example that we looked at was sunstone therapies. It's not really group therapy. It's more like group monitoring, where using closed circuit TV, one senior clinician can monitor 4 patients in 4 different rooms, and thereby significantly enhancing the capability of the clinicians that are available.
Oh, that's really interesting. I mean, I think there are probably different ways that this can pan out later on, depending on maybe how the therapy pre and post is segregated, maybe post integration sessions that are later on become group therapy. But I think this is something that's evolving for sure. Just generally speaking, I know you probably haven't done formal analyses in these areas, but if you had to guess, right now, what do you think is most cost effective when you compare MDMA assisted psychotherapy for PTSD to, let's say, ibogaine for opioid use disorder or psilocybin assisted therapy for depression?
Yeah. So early days, we only have one completed phase 3, well, 2 completed phase 3 trials, and that's for MDMA for PTSD. Nothing else. We don't have phase 3 results yet. So with that caveat, let me say that it seems to me, and this is also just canvassing the opinion of various clinicians I've spoken with, it may be that the disorders for which psychedelic therapy is most effective are behavioral disorders and addiction. So alcohol use disorder, tobacco addiction. You mentioned opioid use disorder and ibogaine. So it could be that those disorders, maybe eating disorders, anorexia, OCD. It could be that, again, those behavioral issues may be more effectively addressed by psychedelic therapy than something like depression. So we will see, but that's kind of what well-informed clinicians are saying to me.
Yeah, I think that makes sense. I guess in general, just like how MAPS started off their trial by picking people that hadn't responded to anything else, people that were especially difficult cases, and those responded best. It does seem like maybe in general there will be a trend of the more difficult the indication, the better and more cost-effective psychedelics will work, because there's just not much to compare it to. So I guess we'll see if that pans out. What I understand we're coming up on the hour, and I know that you have a hard stop. Is there anything that you wanted to touch on that we didn't get a chance to? Is there anything that you want to leave the listeners with, Elliot?
Yeah, I would be happy to just describe some of the work that we're doing now and sort of how we see our mission. So we're an academic entity, and we're committed to rigorous, scientifically defensible analysis. That's kind of where we think we add value. And we think it's important that other researchers, payers, government policymakers can go to a source of information that's not biased. So we don't have conflicts of interest, and we're really committed to that. And we really see our role as contributing to the public good, as is consistent with an academic body. So, for example, we are pretty close to completing a cost effectiveness model for major depression that would allow the evaluation of psilocybin or really any psychedelic therapy for major depression. And we plan to do the same with psilocybin for alcohol use disorder, psilocybin for tobacco cessation, and ibogaine for opioid use disorder. And our plan is to make this open source, publicly available to any qualified researcher with appropriate safeguards and a friendly user interface and a manual and support from experts who can update it so that at any given time, it represents the best science on the disease, like on depression, for example, that's available. So we're really excited about that. I think it's a waste that every pharma organization needs, every pharmaceutical company in the space needs to create their own economic model, and it's proprietary. It's just it's inefficient, and I'm offended by inefficiency. And
like a good economist.
And I also just think it would be a contribution to the field to have those models out there and publicly available to move this forward. So that's an example of a major focus is to get these models out there and have people critique them and improve them and make suggestions and like that. So that's a big part of what we're doing. The global aspect is sort of nascent, and I could mention other projects, but I think maybe that's covers the.
Yeah, no, thank you for sharing that. It's very interesting and worthwhile work. Where can people follow your work? Is there a website or a Twitter account that you want to mention?
Yeah, so we are the Global Initiative for Psychedelic Science Economics, GIPSE, and we're on the web, so you can find us there. And I'm at also just email me. I'm at emarseille1 at berkeley.edu.
Very brave man for putting your email address out there like that.
Yes.
Elliot, thank you so much for taking the time to do this. Really appreciate it. Hopefully we'll get to do this again sometime and go even deeper.
Yeah.
Thank you guys both.
Thank you, Bram. I really appreciate the opportunity, Samantha. Thank you. And we'll be in touch.